Welcome to my study guide for Chapter 29, Heart Failure for Medical Surgical Nursing. Chronic heart disease remains a progressive condition that can lead to serious complications regardless of advances in technology. Heart failure is a clinical syndrome resulting from structural or functional cardiac disorders that impair the ability of the ventricles to fill or eject blood. It was once referred to as congestive heart failure due to the clinical presentations of pulmonary or peripheral edema. Now, heart failure is characterized by signs and symptoms of fluid overload or inadequate tissue perfusion. This results because the heart is unable to generate enough cardiac output sufficient enough to meet the body's needs. The failure may be in the ability of the heart to contract, which is systolic dysfunction, or the ability of the heart to fill, which is diastolic dysfunction, and both occur on either the left or the right side. Some cases of heart failure can be reversed, but it is dependent on the cause. It can be acute or chronic. Chronic heart failure can typically be treated with lifestyle changes and medications to prevent episodes of acute decompensated heart failure, which is characterized by exacerbation of symptoms, decreased cardiac output, and low tissue perfusion. Risk of heart failure increases with age and is most common in patients over 75 years old. This is the most common reason for hospitalization of patients older than 65 years old and the second most common for people visiting the physician. 24% of patients return to the hospital within 30 days. This can be prevented by adequate outpatient treatment and compliance. Increased incidence of heart failure are related to the increasing aging population and heart attack survival rate improvement, meaning that people are living longer. Approximately 50% of patients diagnosed with heart failure die within 5 years of the diagnosis. Left-sided heart failure is either a systolic or diastolic dysfunction, which can be identified using an echocardiogram. The most common type is systolic, where the left ventricle is weakened. Diastolic failure is where the left ventricle muscle is stiffened, inhibiting its ability to completely fill. The physician will assess the heart's ejection fraction during the echocardiogram to determine the type of heart failure present. This is calculated by subtracting the amount of blood present at the end of systole from the amount at the end of diastole. A normal ejection fraction is 55 to 65% of ventricular volume. A normal ejection fraction is found in diastolic heart failure, but is greatly reduced in systolic heart failure. Left-sided heart failure causes blood to back up into the left atrium and then into the left pulmonary circulation. Right-sided heart failure commonly occurs as an effect of left-sided heart failure. The heart is not able to pump blood into the pulmonary system, causing blood to back up into the systemic circulatory system. Severity is determined by patient symptoms. Using the New York Heart Association classification of heart failure, Class 1, no limitation of physical activity is noted, and ordinary activity does not cause undue fatigue, palpitation, or dyspnea. Class 2, there's a slight limitation of physical activity, comfortable at rest, but ordinary physical activity causes fatigue, palpitations, or dyspnea. Class 3 shows marked limitation of physical activity, but comfortable at rest. Less than ordinary activity causes fatigue, palpitation, and dyspnea. And then Class 4, they are unable to carry out any physical activity without discomfort, symptoms of cardiac insufficiency at rest, and if any physical activity is undertaken, discomfort is increased. The American College of Cardiology and American Heart Association classification of heart failure has stages. Stage A, or alpha, patients at high risk of developing left ventricular dysfunction but without structural heart disease or symptoms of heart failure. Characteristics include hypertension, atherosclerotic disease, diabetes, and obesity. Treatments include risk factor control and ACE inhibitors or ARBs. In stage B, or Bravo, patients with left ventricular dysfunction or structural heart disease who have not developed symptoms of heart failure. Characteristics include a history of myocardial infarction, left ventricular hypertrophy, low ejection fractions. Treatments include implementing stage A or alpha recommendations plus beta blockers. In stage C, or Charlie, patients have left ventricular dysfunction or structural heart disease with current or prior symptoms of heart disease. Characteristics include shortness of breath, fatigue, and decreased exercise tolerance. Treatments include implementation of stages A and B recommendations, plus diuretics, sodium restriction, an implantable defibrillator, and cardiac resynchronization therapy. In stage D, or Delta, patients have refractory end-stage heart failure requiring specialized interventions. Characteristics include symptoms despite maximal medical therapy and recurrent hospitalizations. Treatments include implementing stages A, B, and C recommendations, plus end-of-life care, extraordinary measures such as cardiac transplantation and mechanical support. Etiology of heart failure. Causes of heart failure include coronary artery disease, hypertension, cardiomyopathy, valvular disorders, and renal dysfunction with volume overload. Diabetes increases risk. Atherosclerosis of the coronary arteries is a primary cause, and coronary artery disease is found in the majority of patients. A heart attack damages cardiac muscles, resulting in weakened contractions. Extent of cardiac death correlates with the severity of heart failure. We may be able to improve myocardial oxygenation and ventricular function, as well as prevent further necrosis by revascularizing the coronary artery via percutaneous coronary intervention, or PCI, or through coronary artery bypass grafts, which is CABG. Hypertension increases the afterload of the heart, increasing the amount of force needed to eject blood from ventricles. This can be pulmonary or systemic hypertension. This increased workload is a compensatory mechanism because it initially increases contractility but leads to hypertrophy of myocardial muscle fibers. Chronic hypertension and hypertrophy can lead to diastolic dysfunction due to the impaired ability of the heart to fill completely. Cardiomyopathy is a disease of the myocardium and presents as three major types: dilated, hypertrophic, and restrictive or constrictive. The most common type is dilated, where it causes diffuse myocyte necrosis and fibrosis, which then causes heart failure. Dilated cardiomyopathy could be idiopathic or as a result of some other inflammatory process such as myocarditis or from a substance such as alcohol or doxorubicin. Remove the cause of the cardiomyopathy and the heart failure may resolve. Valve problems can lead to heart failure. Valve prolapse may cause blood to flow backwards, getting stuck in the heart. If a valve is hardened or stenosed, more pressure is needed to move blood forward. And these changes in valves increase the pressure in the heart, which increases cardiac workload. Systemic conditions can lead to heart failure. More than 40% of patients with chronic heart failure have impaired renal function. This is called cardiorenal syndrome. Cardiac and renal function are intricately interdependent, and failure of either organ causes injury to the other, creating a vicious cycle. Table 1 describes the Acute Dialysis Quality Initiative classification of cardiorenal syndromes. The general definition is disorders of the heart and kidneys in which acute or chronic dysfunction in one organ may induce acute or chronic dysfunction of the other. Type 1, acute cardiorenal syndrome, is the acute worsening of cardiac function leading to renal dysfunction. Type 2 is the chronic cardiorenal syndrome, where the chronic or abnormalities of cardiac function leading to renal dysfunction. Type 3, acute renocardiac syndrome, is the acute worsening of renal function causing cardiac dysfunction. Type 4, cardiac chronic renal cardiac syndrome is the chronic abnormalities in renal function leading to cardiac dysfunction. And type 5, secondary cardiorenal syndromes, are systemic conditions causing simultaneous dysfunction of the heart and kidneys. Cardiac rhythm issues can result in heart failure because the impaired contraction decreases the overall efficiency of cardiac function. Other factors that can worsen myocardial function include hypoxia, acidosis, electrolyte abnormalities, and chemotherapy. Pathophysiology. Heart failure usually occurs before the patient experiences any signs or symptoms, which include shortness of breath, edema, or fatigue. The body will activate compensatory measures in an effort to cope with the heart failure, which are often responsible for the clinical signs and symptoms. In systolic heart failure, the decreased blood flow is sensed in the aorta and carotid arteries by baroreceptors. These receptors send this information to the sympathetic nervous system, which will then cause a release of epinephrine and norepinephrine. The body responds by raising heart rate and contractility in an effort to increase flow through the aorta and carotid arteries, a negative feedback system. Because the flow problem is related to heart failure, a continued response would be necessary. The baroreceptors would keep sending low flow signals, causing the SNS to release epinephrine and norepinephrine. This causes negative effects such as vasoconstriction in major organs, such as the skin, GI tract, and kidneys. The kidneys will respond to this decrease in perfusion by releasing renin. Renin converts angiotensinogen to angiotensin 1. When angiotensin 1 reaches the lungs, the angiotensin converting enzymes, or ACE, within the pulmonary circulatory system convert angiotensin 1 to angiotensin 2. Angiotensin 2 is a very strong vasoconstrictor that increases blood pressure and afterload, as well as stimulating the release of aldosterone from the adrenal cortex, which causes the renal tubules to retain fluid and sodium, which would increase blood volume. This is why patients experience fluid volume overload when they have heart failure. These mechanisms increase the stress placed on the ventricular wall, increasing cardiac workload. Again, when the heart muscles are under duress or overstretched, the heart tries to counter-regulate by releasing natriuretic peptides such as ANP and BNP, or brain type. Typically, this protective measure is not strong enough to overcome heart failure. In summary, a cascade of events occurs during heart failure, starting with the low flow conditions at the baroreceptors in the vessels leaving the heart.